Hi, everyone, and welcome to Nurses Notes 101. Today, we're going to be talking about heart failure. Heart failure is a classic topic when you're in fundamentals and also on the CCRN. The outline for my heart failure presentation is here. So, what is heart failure? Left and right heart failure, how they look different. Pathophys of heart failure, causes of CHF, clinical manifestations of left and right sided heart failure, complications, assessments, diagnostics, medical management, including pharmacology and nutrition, nursing management, assessments, planning, priorities, and home care guidelines. What is CHF? Heart failure or congestive heart failure is the inability of the heart to pump effectively. It results in fluid overload and inadequate tissue perfusion. Heart failure is a myocardial or cardiac muscle disease due to dysfunction in either the pumping of the heart or the filling of the heart. It can cause either pulmonary or systemic congestion, and it can be a life-threatening condition. It is progressive. Medications and lifestyle changes are usually what helps decompensated heart failure and will help the patient from becoming decompensated. Left versus right-sided failure. Left-sided heart failure causes pulmonary congestion. This is because the left ventricle of the heart backs up into the pulmonary arteries. This causes pulmonary interstitial edema from high venous pressures. So, as you could kind of picture, the left ventricle is backing up. Right behind the left ventricle is the pulmonary artery. The pulmonary artery then feeds back into the lungs. If all of the blood from the left ventricle can't pump through, it's going to go back to the lungs, causing pink frothy sputum, shortness of breath, dyspnea, trouble with activities. These are usually typical heart failure symptoms that we would see for the left side. Right-sided heart failure causes peripheral congestion, and this is when the patient's going to get more of those hepatomegaly symptoms, dependent edema symptoms, and this is from inadequate ejection of blood to the right side of the heart. This causes venous pressures to also increase, which can lead to jugular vein distension. So that's when we see someone's neck veins and they're bulging out. Um, if you see they have very puffy neck veins, that can be an indication of heart failure. Um, let's see. There are different stages of heart failure. Within these stages, it consists of stages from A to D. A, visualizing no symptoms and no structural disease, and a D, visualizing symptoms potentially with structural disease and intervention necessary. The pathophysiology of heart failure. Heart failure is actually from our bodies. So our bodies is trying to compensate. Um, when our heart is overworked, neurohormonal compensatory mechanisms are activated. Systolic heart failure results in decreased blood volume ejection. The central nervous system then, with systolic heart failure, releases epi and norepi. This also decreases renal perfusion, which causes a release of renin and promotes the formation of um, angiotensin 1. Angiotensin 1 is converted to angiotensin 2 by ACE and then stimulates the release of aldosterone, which causes sodium retention, decreased urine output. Also, this will then decrease muscle and myocardial fiber contraction, and that causes heart thickening and thickening of the heart muscle. Causes of congestive heart failure. Causes of this disease or coronary artery disease. That's the number one reason for heart failure. So, this is when plaque builds up in the arteries, either from diet, lack of activity. When your LDL is too high, that is the number one risk for heart failure. Ischemia also can cause heart failure. This is when heart cells are deprived of oxygen, and this results in lactic acidosis. If a patient has cardiomyopathy, this can be a reason for heart failure as well. Systematic or pulmonary hypertension can cause heart failure due to an increase in afterload from hypertension. Um, it could also affect the myocardial fibers. All kinds of cardiac disease can cause heart failure, anything that's going to increase pressures in the heart and increase cardiac workload. Manifestations of left versus right heart failure. So, like I said before, since the left ventricle is not pumping adequately, it's going to back up to the lungs. So, when you think of symptomology of left heart failure, think left lungs. So, any kind of abnormal lung symptoms, so dyspnea, shortness of breath, cough can be usually dry and non productive. They're going to have crackles in their lungs. And they can potentially have a low oxygen saturation due to fluid accumulation in the alveoli. Right-sided heart failure is usually caused from backup of systemic circulation. So this is going to cause engorgement, enlarged liver, high abdominal pressures, just increased volume within the body. GI distress due to fluid in the peritoneal cavity, and then this can also cause a decreased appetite due from venous stasis as well. Complications of heart failure, high or low potassium. So, a lot of times, most of the times, whenever I think of a heart failure patient, I think of Lasix because all my patients who have heart failure are usually fluid overloaded because sometimes they have a combination of left and right heart failure. So, they're going to be on Lasix around the clock, usually 40 milligrams. So, getting continuous Lasix is going to give someone hypokalemia, all right, or low potassium. Hyperkalemia can be from ACE inhibitors, ARBs, and or spironolactone, which are other medications that patients with heart failure can get. Prolonged diuretic therapy from something like Lasix can also cause hyponatremia, which can present the patient looking like they're weak, like they have disorientation and muscle cramping. These patients can also be dehydrated and have hypotension from diuretic therapy as well. And this can be from overdiuresis or a depletion of too much fluid. How to assess and diagnose heart failure. The usual diagnostic tools that are used are EKG, chest x-ray, echo Doppler, TEE. So one of the most definitive I would say would be like a TEE or an echo because we can really see the congestion there and we can see how the LV is functioning. Chest x-ray is a good place to start. I'm sure they will start there just to see how the lungs look and how much the patient potentially is decompensated. And an EKG can show abnormal rhythms from this heart failure. Extra ways to diagnose a patient would be with a PET scan, stress test, cardiac cath. Those are a little bit extra. I would say we would use the priority assessments first, the priority diagnostic tools, and then the ones listed as extra, just as supplementary. I would even say those are more outpatient. Typical labs that are ordered, digoxin levels if they're on it, PT, INR, PTT, electrolyte levels. We're going to check their pulse ox probably continuously. BUN creatinine and assess their urine output to see how their kidneys are functioning. We want to see how that how the sympathetic nervous system is working. So if it is in overdrive, we're going to see the BUN creatinine go up and the urine output go down. So we want to make sure that it's okay. serum albumin levels, especially if they're third spacing, if they have a lot of edema, we can give albumin to help keep that fluid within the blood vessel. CBC, thyroid studies, and look at all of their cardiac enzymes, troponins, things like that. Medical management of heart failure. So, medical management of heart failure includes an array of medications, but these are typically the ones that you will see: ACE inhibitors, angiotensin 2 receptor blockers, diuretics, beta blockers, calcium channel blockers, and not medication, but also these patients will be on a low sodium diet. ACE inhibitors work by promoting vasodilation and diuresis. It decreases the afterload of the patient, so the pressure that the heart has to pump against, and preload. So by decreasing preload, systemic vascular resistance is decreased. Angiotensin 2 receptor blockers, or ARBs, they decrease SVR as well and improve cardiac output by blocking the conversion of angiotensin 1 to angiotensin 2. So that also prevents the development of aldosterone, which prevents that sodium retention. So hopefully will help with that dependent edema. And a lot of times they order ARBs for African American patients as well. Uh, it has been seen that it's more effective for them. Beta blockers are also are also treatment of heart failure. It reduces the effect of the SNS, which is what we want. It's going to also decrease blood pressure and decrease heart rate. Diuretics, like I said before, like a Lasix or a Bumex or spironolactone, is going to help with those fluid overload patients. It decreases extracellular volume by putting out the extra volume through the urine. Calcium channel blockers are also another good option to give heart failure patients. However, it is definitely contraindicated for people with systolic heart failure. It causes vasodilation and it has some effect on the SVR as well. Nursing management of heart failure. Our main goal with these patients and our main job, I should say, is to do a thorough assessment. So, one of our key assessments is actually daily weights, no matter if you're in the ICU or not. I work in the ICU, but even on the floors, um, we have core measures for heart failure patients, and daily weights is important. We want to see if the medication that they're getting currently is keeping them on a steady path. An unsteady path would be characterized by weight gain. If they're gaining more than 2 to 3 pounds between days, that's a cause for concern. So they probably need either more diuretic therapy, and it seems like their SNS is really working themselves up and they're retaining fluid because of it. We want to assess their health history, physical exam, heart sounds, lung sounds, listen for crackles, listen for murmurs, JVD if they have any distension here, urine output, if it's adequate or if it seems low, tell the physician, and then looking for edema. Our nursing diagnosis for these people, it's probably going to be something like activity intolerance, ineffective breathing pattern, and then our goals for them would just be to optimize medical management, education, promote activity tolerance, and manage fluid volume. Nursing priorities for these patients is to improve myocardial function and perfusion. We also want to reduce fluid overload and prevent any complications. The best way to prevent complications for these patients is to educate. They need to understand the importance of a low sodium diet. They need to understand they need to take their meds at the same time, and they need to understand the importance of taking their weight at home. This is something, probably the number one thing that can prevent readmissions for them. If they see themselves gaining excess weight, more than 2 to 3 pounds within a day period, it's something where they should call their doctor. They'd have to revamp their meds. Home care guidelines. Pretty much what I said before. Only thing I'm going to include is smoking cessation. If they do smoke, that is one of the major causes of heart failure and myocardial disease. This can cause, like we know, atherosclerosis and plaque buildup, and just stenotic vessels in the heart. So we don't want any further complications, which would further progress their not congenitive, their congestive heart failure. We want to answer their questions, make sure they don't cut their pills also. We don't want them, let's say they're on Lasix. We don't want them to take their Lasix at night because then they're not going to want to take it. They're going to be up all night going to the bathroom. We want them to take their Lasix early, and we want them to take all of it. I've heard of patients before cutting Lasix in half because they're like, oh, I don't pee as much. It's easier to tolerate. You don't want them to do that. You want them to take all of the medications because then it could negatively affect their outcomes. And I know as much as they don't want to go to the bathroom every 5 seconds, they are not going to want to go back and forth to the hospital either. So these are just things that are important to tell them. Take their medications the right way, light exercise, um, and then sleep with an adequate amount of pillows. A lot of times, these patients, especially if they're in fluid overload, are going to need more pillows behind their head, and that's okay. Um, if they feel excessively congested, if they're getting more swollen, if they're gaining weight, these are all signs to call their doctor. If they feel short of breath, if they can't catch their breath, if they feel their heart is racing, if they are seeing blue extremities, blue lips, that is a medical emergency. I would have them call 911. So these are all important things for them to note if their disease is progressing. Okay. Thank you guys for watching Nurses Notes 101. I'm Nurse Alexa. See you next time.